Hello people, this is Dr. Muskaan this side, and today I'm going to discuss one case. It is all about CNS case, and I'll make you go through the CNS examination part. What is the main thing is we feel it difficult to do CNS examination, but I will make you feel it very simple if you will come with me till the end of this video. So let's start. So let me tell you some history of the patient before starting CNS examination. Here is 58-year-old male who has came to ER with chief complaint of dizziness, tendency to fall on the right side and numbness in the right side of the body since 2 days. On arrival, ABCS was done, airway was patent. On breathing assessment, respiratory rate was 14 per minute, SpO2 was 96% on room air. On circulation assessment, pulse was 74 per minute, BP was 142 by 98 mmHg, sensorium was alert, that is GCS was 15 by 15, E4, V5, M6. Just don't get confused when I'm telling you about ABCS part. It is nothing but airway, breathing, circulation and sensorium, which we see when patient come in emergency. We see airway, is there any sign of airway obstruction or not. Signs of airway obstruction are dyspnea, dysphagia, dysphonia, stridor, hoarseness of voice, somebody's choking, somebody's putting his hand on the neck and saying mujhe saans nahi aa raha, like this. We do the breathing assessment to see if there is some desaturation or not, कि हमें वेंटी पे लेना है पेशेंट को, नहीं लेना है. रेस्पिरेटरी रेट देखते हैं टू सी कि टेकेपनिया है कि नहीं है, एंड देयर आर वेरियस रीजंस respective to the system involved, the disease the patient is having. So on circulation assessment, we see BP and your pulse to see tachycardia and your hypertension. Of course, these two parameters, your BP and pulse, helps us to take us towards the diagnosis of shock. Sensorium is alert, GCS is 15 by 15, E4, V5, M6. So you can go through Glasgow Coma scale, which you are going to learn in your final year in surgery subject, and you can ignore this line if you are not able to understand at this point of time. So yeah, let me tell you about the past history of the patient. Patient was hypertensive and diabetic. RBS on arrival was 254 mg per dl. He is on regular medications, that is metformin and telma. There are no other comorbidities present. Past surgical history, there is history of laparoscopic appendectomy 20 years back. Personal history, he is vegetarian by diet, sleep habits are adequate, he is non-smoker, non-alcoholic, bowel and bladder habits are normal. Negative history. So the negative history part is very important, and when we are in third year or final year, we feel it as a difficult part because we don't know what we have to rule out and why, है ना. तो it comes with time, धीरे धीरे करके वी लर्न कि ये कॉन्सेप्ट इससे भी रिलेट हो रहा है. वी हैव टू रूल आउट द सिम्टम्स ऑफ दिस डिजीज पर्टिकुलर, इफ दिस सिस्टम इज इन्वॉल्व, इफ दिस पार्ट ऑफ दैट सिस्टम इज इन्वॉल्व. Okay, so here is negative history of loss of consciousness, seizures, tongue bite, vomiting, photophobia, convulsions, negligence and fever. And what all diseases I have ruled out here are the three diseases. One is your migraine, other is your Toad's paralysis, yeah, two diseases, and third is your meningitis. Fever, neck rigidity. Okay, with this I have ruled out meningitis. Your Toad's paralysis, which I am telling, it is a temporary limb weakness which occurs after seizures. So seizures I have ruled out to see if there is Toad's paralysis present or not, because patient has come with a chief complaint of weakness in the lower limb. Other things which I have ruled out is loss of consciousness, photophobia, convulsions, vomiting, tongue bite. I was also trying to rule out some very specific findings we see in a case of stroke on a little high level, if it is present or not, because stroke is many times confused with syncope. Syncope is loss of consciousness, there is no tongue bite present, but if it is going towards the क्या tongue bite भी present है और लॉस ऑफ कॉन्शियसनेस भी है एंड ये सडन ऑनसेट हुआ है, तो वी गो ऑन द लाइन ऑफ स्ट्रोक. तो वी ट्राई टू रूल आउट दीज थिंग्स. So I have told you a very little history of the patient, and I want to go towards the CNS examination right now. CNS examination, we are going to see two things. One is a motor examination, other is a sensory examination, and I have practically performed these both examinations on the same patient I am talking right now, and I will attach their links in description. You can either go to those links and see how I have actually performed practically, or you might listen here also and note down what are the basic step wise points कि हाँ ये मोटर एग्जामिनेशन में इतने पॉइंट्स आते हैं, इस पॉइंट में ये है, सेंसर एग्जामिनेशन में ये पॉइंट्स आते हैं. जस्ट मेक नोट्स and then you can go watch that video and you feel अच्छा मुझे ये भी अब करना आ गया, ये भी करना आ गया. You can do like that also. So yeah, motor examination, motor system examination. First we see the bulk of the muscle, and in that we see your forearm, your arm, thigh and leg. We use inchy tape for this and we measure the bulk, and we have to see कि it should be same on both sides of the arm. अगर यहाँ पे 10 है तो यहाँ पे भी 10 होना चाहिए, यहाँ पे 5 है तो यहाँ पे भी 5 होना चाहिए. It should be like that. That means it is normal. But अगर यहाँ पे ज़्यादा और यहाँ पर कम है, means लेफ्ट हैंड पे ज़्यादा राइट हैंड पे कम है, तो that means कि there is some atrophy of muscles or hypertrophy of muscles which we have to see. And what we are going to see in that, if there is atrophy of muscles, there can be main three reasons. One is your cachexia, second is your prolonged hypertonia, and third is your inflammation. But if it is there hypertrophy of muscle, the reasons can be muscular dystrophy or a person who goes to gym. Second point in motor examination is tone of the muscle, in which we see we say to the patient just अपना हाथ ढीला छोड़ दो and you do like this. And अगर वो आराम से हो रहा है या वो एकदम से बहुत फास्ट हो रहा है या वो बहुत रेजिस्टेंस से हो रहा है, you see the tone of the muscle. And what does the tone of the muscle tell us? There is low frequency and asynchronous discharge of the gamma motor neurons, which leads to partial contraction of the muscles, which tells us the tone, or it is also called as physiological tetanus. So upper limb ka tone and lower limb ka tone we have to see. I have seen ki patient has come with the complaints of the right side weakness, and there was hypertonia present in the right side in both upper limbs as well as lower limb, but normal in the left side. And if hypotonia is present, there is no resistance by doctor, and if hypertonia is present, resistance increases by doctor. Means you are trying to resist it but it is going so fast. So ऐसे करके पता करते हैं. If hypotonia is there, there might be lower motor neuron lesion, that is poliomyelitis and syphilis. And if it is hypertonia, there can be upper motor neuron lesion, there can be rigidity and spasticity. If there is rigidity, it includes multiple group of muscles. If there is spasticity, it involves only single group of muscles. Third thing we check in motor system examination is your strength of the muscle, in which there are 5 grades. Grade 0 tells that there is no movement at all. Grade मतलब patient will say कि मेरे से पैर उठाया ही नहीं जा रहा. You say कि please lift, थोड़ा सा उठाने की कोशिश करो, उठ ही नहीं रहा मेरे से पैर. Means grade 0. Grade 1 is flickering of the muscle if movement attempted. Grade 2, movement of the joint eliminating gravity. Grade 3, movement of the joint against gravity. Grade 4 is movement of the joint against gravity with moderate resistance, and grade 5 is movement of the joint against gravity with strong resistance. So in our patient, upper limb and lower limb both strength of the muscle was normal, and in that you have to provide resistance. Like I am telling you of upper limb right now, you will do like this and you will say कि patient को कि अपना हाथ ऊपर करो, तो if he doing like that means power is 5. मतलब ऐसे करके you are going to do, मतलब you are going to check both flexor and extensor. Okay, now I am telling you fourth point, that is coordination of movement. There is different coordination points we examine in upper limb and lower limb. In upper limb we examine finger nose test, draw circle closing eyes, and we check diadochokinesis, in which we say the patient to do supination and pronation movement or radio ulnar movement, or we say adiadochokinesis or dysdiadochokinesis, in which there is diagnosis of cerebral ataxia, because patient क्या करेगा, you are saying कि supination pronation करो, ही इज़ डूइंग, बट आप उसको रोक नहीं रहे हो, यू आर नॉट गिविंग हिम कमांड टू स्टॉप, एंड अचानक से ही डू लाइक दिस, मतलब 2 बारी उसने ऐसे किया, मतलब देर इज समथिंग रॉन्ग। अदरवाइज नॉर्मल पर्सन से को करने के लिए दे आर गोइंग टू डू इट एग्जैक्ट, बिकॉज इट इज़ नॉट दैट डिफिकल्ट टू डू। तो ऐसे करके वी कम टू नो कि अगर डिसडायाडोकोकाइनेसिस प्रेजेंट है, देयर इज सम सेरेब्रल अटैक्सिया। पेशेंट खुद बोलेगा कि मैं राइट हैंड से तो ऐसे ऐसे कर पा रहा हूँ, लेफ्ट हैंड से ना मेरे से मतलब ऐसा लग रहा है कि बहुत वीक है, ऐसे करके बोलेगा। लाइक इन आर केस इट वॉज प्रेजेंट इन द राइट साइड, बिकॉज ही हैज़ ऑलरेडी कम विद द कंप्लेंट्स ऑफ द राइट साइड वीकनेस। अब लोअर लिम्ब का कोऑर्डिनेशन ऑफ मूवमेंट कैसे चेक करते हैं? देयर आर 4 टेस्ट। फर्स्ट टेस्ट आस्क द पेशेंट टू वॉक इन स्ट्रेट लाइन। सेकेंड टेस्ट इज हील नी टेस्ट। थर्ड टेस्ट इज टेंडम गेट, कि आप हील टच करके चल रहे हो ऐसे करके ऑफ द फर्स्ट फुट। रोमबर्ग साइन इज द फोर्थ। We ask the patient to join both the legs, look straight, close the eyes, and if patient swings on closing eye, there is sensory ataxia, and if patient swings on open eye, there is cerebral ataxia present. Fifth we check is gait. In gait we see a hemiplegic है, तो patient will rub right leg like floaters on floor, and there is pyramidal lesion. If there is trampling gait, patient will walk like marching, and there is sensory ataxia. If there is drunken or reeling gait, patient will move here and there. There is cerebral lesion. If there is fascinate or shuffling gait, this patient is of Parkinsonism. Subject will stoop, like झुकेगा वो subject, and body is falling at the center of the मतलब body is falling at the center. He will take small steps, small baby steps to avoid the falling. Next gait is your fifth gait is your waddling gait, in which he will walk like duck. डिस्ट्रोफी होगा, डिस्टीन मस्कुलर डिस्ट्रोफी में मेनली मिलता है वैडलिंग गेट. सो या यू शुड नो अबाउट द टाइप्स ऑफ गेट, हाउ आर देयर मूवमेंट्स, एंड व्हाट यू आर गोइंग टू रूल आउट, व्हाट यू आर गोइंग टू सी इफ इट इज़ प्रेजेंट और इट इज़ एब्सेंट. सिक्स्थ इज योर इनवॉलेंट्री मूवमेंट. कोरिया का पेशेंट आई हैव सीन इन, ही लिटरली डू लाइक दिस, ऐसी मूवमेंट होती है जैसे कोई डांस कर रहा हो. सो जर्की मूवमेंट्स वी से. एस्थोसिस, सुपिनेशन प्रोनेशन ऑन फिस्टोलॉजी, लाइक इट इज लाइक ऐसे ऐसे करके करेगा पेशेंट, सुपिनेशन प्रोनेशन एस्थोसिस में. टिक्स, ब्लिंकिंग आइज, तो आपने वो मूवी भी याद आ रही होगी जिसमें वो आइज ब्लिंक करता था, तो दिस इज टिक्स, इनवॉल्व मूवमेंट. Other is your tremors, resting tremors, pill rolling movement, which is present in Parkinsonism or basal ganglion lesion, and intention tremors, which is tremors on activity, that is cerebral lesions. So this was all about your motor system examination. I hope you have enjoyed, and I will say just take some rest of 5 to 10 minutes and again open this video to learn about the sensory system examination, if I am able to tell you exact and you are understanding it. So sensory system examination में you first you see the tactile sensibility, that is touch, and you see 4 types. One is light touch, other is pressure touch, third is your tactile localization, and fourth is your tactile discrimination. Use cotton for light touch, and for pressure touch use your any pen. For tactile localization you ask the patient कि मैं जहाँ पर पेन रख रही हूँ आपको बताना है कि मैं यहाँ पर पेन रख रही हूँ, टू फिंगर इट आउट. एंड फोर्थ इज योर टेक्टाइल डिस्क्रिमिनेशन. यू यूज़ एनी टू, लाइक यू डिवाइडर होता है ना, वही रखोगे और बोलोगे आपको 2 चीज़ें मतलब महसूस हो रही है कि 2 है, टू चेक कि सारे रिसेप्टर्स वर्क कर रहे हैं कि नहीं कर रहे हैं. एंड what we see from this all, अगर एनेस्थीसिया दिया होता है तो देर इज़ लॉस ऑफ टच. अगर हाइपोस्थीसिया होता है देर इज़ पार्शियल लॉस ऑफ टच. अगर हाइपरथीसिया है देर इज़ लाइट टच विच इज़ परसीव्ड मोर. एंड जो टच का आपने एग्जामिनेशन करना है वो आपको डर्माटोम्स पे करना है, इन विच यू शुड नो द डर्माटोम्स. इफ आई एम सेइंग दिस इज़ माई फोर आर्म, दिस इज़ माई थंब, सो दिस इज़ योर C5, दिस इज़ योर C6, नाउ दिस इज़ योर C7, this is your C8, this is your T1. So these are the 5 points of the dermatome of the forearm. Now the second thing you see in your sensory examination is your pain, in which you will see the superficial pain and deep pain. If pain is absent there is analgesia. If pain is more in one and less in one, मतलब एक हाथ में ज़्यादा फील हो रहा है दूसरे हाथ में कम फील हो रहा है, तो there is hypogeusia, that is partial loss of pain. And hypergeusia, if light touch produces more pain, and it is seen in diseases such as Tabes, dorsalis, syphilisis, STD, and allodynia. Third is your vibration sense. which it might be absent. You can use your tuning fork. आपने ऐसे किया, आपने लगाया स्टाइलेट्रिसिस ऑफ रेडियस पे, और आपने बोला पेशेंट को कि कुछ फील हो रहा है, और उसको जैसे मेरे केस में पेशेंट वो सेइंग कि मुझे नहीं फील हो रहा, बट जब मैं अपने यहाँ पास रख रही थी अपने स्टाइलेट्रिसिस ऑफ रेडियस पे तो मुझे फील हो रहा था. तो एब्सेंस ऑफ वाइब्रेशन सेंस सजेस्ट अस ऑफ पोस्टीरियर ट्रैक लेजन, and one disease is Stapes dorsalis also. Other is your sense of position. You will say the patient कि close your eyes, और आप मुझे बताओ कि मैंने आपका हाथ किस तरफ मोड़ा. He will say right, he will say left, he will say up. Now again I will ask the patient to close the eyes, and मैं उनका हाथ घुमाऊंगी and मैं बोलूँगी ये मैंने किस पोजीशन में रखा है, और दूसरा हाथ भी उसी पोजीशन में रखो. If you do right, that means sense of position is right. Your fifth is sense of shape, size and object, in which you will ask the patient, you will make him hold different objects and you will ask कि क्या है ये. You can make him hold pen, pencil, water bottle, coin, to know कि अच्छा circular object है, small है, big, ऐसे करके. So that is all about sensory examination. So yeah, that's all. I really enjoyed recording this video. I hope you have also enjoyed listening me. And that's all. Dr. Muskaan Bansal is signing off now.